Hello, I am Sridhar, Director of the Nanomedicine Innovation Center at Northeastern University and jointly appointed at Harvard Medical School. Thank you for this opportunity to tell you about our work on renal mass imaging using the QTCE MRA technique. I want to first acknowledge the contributions of my students and alumni from my group, as well as my numerous collaborators, and the support of NIH and NSF that has made this work possible. QTEMRA is short for Quantitative Ultrashort Time to Echo Contrast Enhanced Magnetic Resonance Angiography. We use the contrast agent ferroxetol, which is clinically approved for iron anemia therapy and can be used for imaging off-label with IRB approval. This is a supraparamagnetic iron oxide nanoparticle which is safe for chronic kidney disease patients who cannot undergo iodinated CT or gadolinium-based contrast agent. For scanning, we use an ultra-short time to echo or UTE Siemens prototype 3D stack of spirals whip, which we optimize for ferroxetol scanning. The combination of the contrast agent and the UTE sequence optimized is called QTCE-MRA. Here we will show that this technique yields whole body angiography with exceptional clarity and definition, as you can see from the video on the right. The signal to noise ratio is more than 5 times better than gadolinium-based CE-MRA, and with much higher resolution. In addition, the technique is quantitative in that it enables quantification of the blood volume. Some recent publications are listed here. We recently completed a first-in-human clinical trial of cerebral angiography in 15 normal subjects. The exceptional clarity and definition of the angiograms is clearly visible here. We further showed that QTCE is 5 to 10 times superior to time of flight and to gadolinium CE-MRA. We also established the first human CBV or cerebral blood volume atlas. We have recently focused on abdominal scans in chronic kidney disease or CKD patients who cannot receive gadolinium MRA or iodinated CT. The technique provides excellent rendering of the vasculature of the entire abdomen, as you can see here. And then we can zoom in on individual organs like the kidney or the liver, which are also visible with high clarity and definition. In a recent publication in Abdominal Radiology, we have shown that QTCE is 5 times superior to gadolinium MRA with at least 3 times lower signal intraluminal inhomogeneity. We have demonstrated dynamic scanning with QTCE-MRA by taking quick scans at 20-second time points and with breath hold. Now, this dynamic scanning enables us to separate out arteries and veins. In the full subsequent steady state, all the vessels are equally bright. Here I present a case study of a 61-year-old female with stage 3 CKD, an eGFR of 30 and therefore contraindicated for gadolinium scanning. She was referred to us by Dr. Stephen Chang, head of urological surgery at Brigham and Women's Hospital, for ferroxetol enhanced MRA to assess the renal mass observed at the lower pole of the kidney at the site of a previous nephrectomy. Here I show some of the 2D scans, both pre and post on the left, and then the right video shows a 3D rendering of the vascular system by QTCE-MRA with the renal mass rendered in green. The dynamic QTCE-MRA scans showed that there was no contrast enhancement in the renal mass, and therefore it's not vascularized. We reported it as Bosniak stage 2F with no enhancement. Indeed, follow-up ultrasound imaging after 6 months showed that the mass has decreased in size, consistent with the MRA diagnosis. The second case study I want to discuss was a 74-year-old male with stage 4 CKD, eGFR of 29. He was referred to us by Dr. Stephen Chang, who was concerned about a complex renal mass in the left lower pole of the kidney that was likely to represent renal cell carcinoma rather than an angiomyolipoma or an oncocytoma. Again, here you can see on the left some of the 2D scans, and on the right, the 3D rendering shows the presence of several masses, including the complex mass that is of concern. The results of the dynamic QCE MRA scans are shown here. On the extreme left panel, the enhancement in the vessels and also in the tissue, including the ipsilateral and contralateral cortexes, is shown quantitatively. In addition, we can see that while two of the masses are not enhanced and can therefore be classified as cystic, the complex mass does show enhancement. In the middle panel, the quantitative blood volume assessment shows that the enhancement of the quantity of the complex mass is comparable to that of the cortex tissues, showing the presence of vascularization. A more detailed scan on the right is shown, and you can see that the complex mass is itself quite heterogeneous, with regions of high vascularization and many that are unvascularized. In this case, the complex mass is clearly suspect, and the conclusion was provided to the surgeon for follow-up. QC MRA is quantitative in that we can directly measure the contrast agent concentration in the blood pool. This can be used to calculate the blood volume as a biomarker in any organ or tumor. An example is shown here of an ongoing study in multiple subjects where we have conducted radiomic analysis of 14 parameters of the renal blood volume at both the organ level and the local level. In the accompanying graph on the right here, the blood vessel value of the blood volume is normalized to 1, and the blood volumes of the kidney parenchyma are around 0.2. While examples of cystic masses are near 0 since they're not vascularized at all, and the complex mass that I referred to previously is also shown here. Thus, the QCE blood volume biomarker can be used for quantitative assessment of renal masses, as I've shown here, but also more generally of vascular health in any organ, such as the kidney, the brain, and others. We are combining the QCE MRA vascular map with other data, such as the anatomy structure map using T1, the diffusion map with DWI, and the bold fMRI oxygen mask to create a comprehensive multi-parametric analysis of organs and tumors. We create a per-patient data matrix involving all these parameters and analyze it to create a vascular scoring system for renal masses based on the QCE data, as described in the table below. In conclusion, we have clearly established that QCE-MRA is clearly superior by more than 5 times to gadolinium CE-MRA. Today, there is really no technical reason to use gadolinium contrast enhanced MRA. This technique leads to exceptional angiograms that we are using for surgical planning. Furthermore, the method is quantitative, and the QCE-MRA blood volume is a potential biomarker for renal mass assessment as well as assessment of the vascular health of any organ, such as the kidney, brain, and others. Thank you very much.